Hello, EGP learners, and welcome to this episode where myself and Andy are getting ready for our Christmas special as we round off the year. And we've got a fun packed, I want to say fun, but we'll see, an interesting packed episode on the happenings of general practice for all of you out there today, haven't we, Andy?
Yeah, it's going to be fun to just highlight some of the key stories that we've seen in the press about general practice and in the industry press about general practice over the last few weeks, and see what people out there think about them as well. So yeah, so quite excited. It's the last episode of 2023, which is exciting. So that's really fun to be here with everybody.
Definitely. And we've got some interesting things coming up. The first one we're going to talk about is, I guess, the SCA changes and stuff that's happened. Following that, we've got some financial updates that have happened in terms of things that are out there for you to do right now. So we will give you the links to those, and they are, some of them already down in the show notes if you are watching us on YouTube and stuff already. Then we're going to talk about online consultations because there's been some interesting news around that. And then rounding off, I think we've got more stuff around PCNs and health inequalities and all that kind of thing before we get to some fun things to finish this off.
Yeah, absolutely.
About right, Andy?
Yeah, that's right. I mean, just so people know exactly what's coming up. So we'll be talking about the SCA. We'll be talking about the incentives in general practice consultation that is happening from the government at the moment. We'll be following some stories around do primary care networks have they contributed to health inequalities? That'll be an interesting story to have a look at and have a chat. What are patients' attitudes towards online consultations? The government is asking the DDRB to comment on general practice partner pay, I think for the first time ever. So that'll be interesting to talk about. And I think that's about it. So,
and the GP survey, wasn't there?
Oh yeah, very true. And for the first time, the GP patient survey will be changing questions to ask. I'm trying to remember what it's about. Can't remember, Gandhi, but we'll get there when we
get there in the end.
It's Christmas, but the GP patient survey will be changing.
No problem. So I guess first thing we're going to have a look at is the SCA news. So Andy's probably not up to date with some of this, but they released the information about the SCA from the sittings in November just this week. There's been a lot of furore around some of the stuff that's happening. So the results didn't go as well as I think many people hoped. I know my own trainee, unfortunately, didn't do as well as he'd hoped either. There have been definitely some criticisms landed towards the RCGP in the way that it's being handled. I think there's even a legal case going to them. Interestingly, not around the results, but around the disability access of people who should have more sittings and stuff. So the BMA seems to be getting involved in this as well.
Yeah, I think the BMA are making a legal challenge. Gandhi, just so people understand the SCA, so simulated
consultation assessment.
And just tell us just very, very briefly, Gandhi, just for those who aren't.
So it's the replacement for what was previously the RCA recorded consultation assessment. So it's a simulated patient consultation exam, takes place in the practice of the trainee. 13 cases, simulated patient through a video interface, and that's been the key thing that's been part of this. There's a question around how that video interface is coping with people. There's been some suggestions of people being given the wrong marks. There's been some suggestions of tech difficulties, which I know I even did an episode on to try and help people manage that. But despite knowing all that, despite helping my trainee do as much of that as possible, he still had tech difficulties because that's just the nature of the beast, isn't it, sometimes? But yeah, it's unfortunate. I think there's definitely something around the availability of the exam for those that have failed. So how does that work? And what does that mean for them moving forward and their careers? There's definitely some social media furore around it as well. I don't think we're going to go into that because, let's be honest, it's not necessarily our wheelhouse and things. But I guess what I would say is I do think the RCGP's got some serious PR work to do around this. I've never been shy about telling them that they need to sort out their PR, but they absolutely need to get cracking and respond to the people. And I don't know, figure it out, shall we say. But we shall see if they do or they don't. I don't know.
So probably something to watch in 2024 to see how that gets resolved and what is next for the SCA.
So next is the big one, which is we're talking about, which is the financial incentive stuff. So I know you've had a brief read. I've had a quick read, Andy, as well. It's interesting, isn't it?
Yeah, it's interesting. So the government is embarking on a consultation with people who work in primary care, patients, other stakeholders. It's a fairly open consultation about incentives in primary care and the role that they play in primary care contracting, primary care funding, and moving the focus of primary care to where it ought to be in terms of looking after long-term conditions and so forth. So I guess the biggest incentives that have been in place in primary care for the last few years are things like QOF and more latterly the IIF. And again, there might be people out there who don't fully understand that. Gandhi, are you able to just very, very quickly explain QOF and
Yeah,
IIF,
sure.
how they work?
So QOF stands for Qualities and Outcomes Framework. It's been around since 2004, since the last major GP contract review back then, where general out of hours was taken away and it was replaced with this framework, which each year subsequently evolved. It's about trying to evaluate what general practice does and a financial reward for some of that. So things like diabetes care, hypertension care, stroke care, various other things. Over the past few years, that it's evolved into other parts. So they're now included quality improvement into some of that and various other mechanisms, including immunizations and things. The IIF, best way to think about it, that's the same thing, but over a network rather than a practice. So impact and investment fund. And it looks at data, it looks at population level data to try and see how that healthcare is being delivered. I think there's a question now that comes through, is QOF fit for purpose? This is the question that's been asked for the past few years, actually, particularly when during COVID, a lot of QOF incomes had to be guaranteed and suspended in some ways because of the fact that because of the changes during COVID, we couldn't actually assess people. And it makes up such a significant proportion of funding for practices that without it, they would definitely go under and things. So there is this question of, is it the right way to check for what it's checking? Is it checking for the right things? I guess is also the question. But this survey that's being perpetuated around is a consultation by the government on what is the best way forward for this. And it'll be really interesting to see what comes from it. I know I've been doing the survey in the background. I'm about 15 questions deep after about 20 minutes and still going, but we'll see if I get to the end soon. But I don't think it's as mammoth as some of the other questions we've had to do.
So Gandhi, can I just check, can you still see and hear me?
Yes.
The first question, that's fine, because something strange is happening to my browser, but I think I can carry on. I can't see you at the moment.
Oh, weird.
I'll try and resolve that in the background as we go. But I guess we started by showing an article from Pulse, which is really good actually for some of the commentary around this consultation and some of the conversations that are starting in each of the areas. But to really understand it well, I suggest that people just go straight to the government's website actually, because there's a really good breakdown, and actually you can then click through and actually do the consultation, which is probably the best way to understand the contents. How long do you reckon it would take to complete, Gandhi?
I've got a feel, so I haven't quite finished it yet, but I suspect it'll take you about 10-15 minutes or so.
That's not bad, is it?
No, it's not, and it's not a complicated questionnaire. It's very simple. I mean, it's normally 3 or 4 choice MCQ, and then a question afterwards to explain your answer. So it's not a bad questionnaire, I don't think, to do. It seems, I think they've even listed the questions on that page, haven't they, Andy? So it gives you a rough idea. So I'm if you go down, I'm at the continuity of care question in the background where I've been doing and stuff.
Yeah.
But I guess this is not the only question I would recommend people have a look at. We did in our previous episode talk about 2 other ones, particularly for general practice to focus on. So this is the BMA GP survey that they're doing. So research.net/r/BMA-GP23. And also there's another one that came out about a week or so afterwards, which is around practice finance. So research.net/r/practice finance DES. So for December 23 with a capital D there and stuff. And I would highly recommend people complete those questionnaires. The deadlines aren't too far away, although I think the practice finance one is the 1st of January or something like that. So, these are things that are going to help support and inform, I think, how the GPC are going to be negotiating with the government in terms of the changes to the GP contract, which is the big thing I think many of general practice is keen to see and understand. So I would really recommend people have a look at those. The finance one, unfortunately, you need some details about your practices and stuff. I'm afraid that's probably the most complicated one. I know the GP one we did last time. Well, we tried to do last time, didn't we, Andy?
Going and going and going.
55 questions. Yeah.
And if you're going to spend time on the free text boxes, I mean, it might take you a little bit longer to do some of these, because I know with the role of incentives in primary care, there's opportunity to put things in the free text boxes, and people might want to be a little bit more thoughtful about that. So it can probably take as long as you want it to, really, but probably no less than about 15 minutes, I suspect. Is it worth just showing people what the main questions are in the incentives?
Yeah, if you just scroll down a little bit, we can. I mean, it's fairly simple, to be honest. It's pretty decent. So it's just, what are your thoughts on incentivizing? What are your thoughts on targets? What are your thoughts on how it affects health and qualities? I think then talks inevitably about other kind of things like access, continuity is in there. If you go scroll down a little bit later, and that's about as far as I've got so far. It does look at it also from a practice and from a PCN perspective. Or wider. I think it even includes place in there, Andy. Oh yeah, congratulations, Andy, on your deputy place role.
Yes, new job starting in the new year. I'll be deputy clinical director for the place-based partnership in Nottingham City, so that's really exciting. Yeah, thank you. Nice to we can announce that on EGP Learning. There were some interesting themes, Gandhi, that I'd sort of picked up on in this consultation, because the government doesn't do this very often.
They don't. No, not at all.
So this might herald quite a big contract change or contract review. So I think, when we predict the end of QOF, we might be right. It'll be replaced by some other incentives scheme, I think, is what's being indicated by the fact that the government are having this consultation. But I think it looks like the intention is to replace it. And a few themes kind of struck me. I'm just trying to change so there's just the two of us on the screen, Gandhi, but my interface is all mashed, unfortunately, here. So the first one is they ask about outcome-based targets and activity-based targets. So I think there might be an acknowledgement that can you still see?
I can hear you. I can see and hear you. I'm sorry if things go wacky on your end.
They talk about outcomes-based versus activity-based targets, and a lot of there's a mixture, isn't there, currently in QOF and in what was previously expected from IIF. But they talk about whether the practices in disadvantaged areas or with disadvantaged populations can sometimes be adversely disadvantaged by these sorts of incentives, in terms of outcomes. How likely you are to meet certain outcome thresholds can be dependent on your population rather than how hard you work and what you do. So I think, for example, reaching HbA1c targets for diabetics might be an example of this, or getting people in for their children to be vaccinated, for example, might be another example. So they seem to be open to a discussion about, whether it's right to set outcome-based targets, activity-based targets. I think there might even be scope for relative improvement targets as a way of combating that. So I think that's really interesting, and I think it's really important that people engage with this, because I think that this will result in some quite significant contract changes, in my opinion. Another thing, Andy, and I'd be just know your opinion on this, really. There's some questions around the level at which targets are set. So currently IIF is about PCN level targets, and QOF has always been about practice level targets, but it seems like they're opening up a discussion about at what level targets should be set. So I do wonder if some targets could be elevated from the QOF practice level to the primary care network level. That seems to be indicated, which would again be a really big change.
Higher, to be honest. Yeah.
What do you think about that, Gandhi? Would that be?
I think if you're going to take funding away from practices, then that would never be a positive thing. We know that practices already are massively underfunded for the work that they're doing, and last year I predicted practice closures. I think if there wasn't to be the maintained funding, that we're going to probably see even more of that and stuff and things. I think the survey suggests they may even look higher than PCN, so at place and even ICB levels. So that would be really interesting, because I think that really blurs the lines a bit more. How do you compare, St Anne's and Bulwell to West Bridgford, for example, in terms of outcomes? You can't. They're completely different populations and they work completely different ways. So the
interesting thing around ICBs and place level, I thought was the discussion around the flexibility of ICBs to set local targets. So that idea that not all of QOF or IIF might be the same all over the country, but that there might be some local flexibility to set local targets. I thought that was interesting, and how you feel about that might depend on how you feel about your ICB, I guess. But that would be a big change as well. There's also some discussion about patient experience, and they talk about patient experience of access, and they also mention continuity as well, and whether payments could be related to things like the GP survey and patients' experience of access and experience of continuity, which again I think would be quite new territory for QOF, at least. Obviously, we're seeing that with IIF this year, but that would be new territory for QOF. So there's some really big things here. So I think it's really important that people engage with this survey.
Definitely agree with you on that one, Andy. And I think, it comes through. I think some of the EGP learners are very interested in this. So first of all, just to reassure you, Miss Melody, saying that we both look and sound great, so you don't need to worry about how you're coming through. Jamie mentions, and interestingly, Jamie's coming through from Twitter. So this is the first time we've been able to bring Twitter comments onto the stream. So if you are watching us on Twitter, hi, hello. I know you've been able to see us before, but not comment, but you can now. QOF really did make a huge leap forward at its inception, but probably a little bit less now. The government will need to pay money towards things around primary care rather than core. And then finally, he comments on about the fact that he worries about how NHSE collect appointment data, but not collecting it from other places. So that's a big one in terms of online consultation data. We know that that's not coming through in the way that it should be in GPAD. And I've been a massive critic of that and stuff. But, maybe one day it will come through and stuff and things, but we shall see. Hopefully then we will have accurate representation of what general practice is actually doing.
Yeah, absolutely. I mean, I know some practices will create an appointment within the ledger for their electronic consultations and things like that, but that's really arduous and labor intensive for someone to create those registers.
Waste of primary care time.
Waste of time. Absolutely.
Anyway, speaking of online consultations, that's probably a great segue for us to talk about online consultations, isn't it, Andy? And actually, there's been a recent article that came out around this saying that actually online consultations are not as bad as we think for some people. So this recent article in the Pulse, most patients find advantages of online GP consultations. So this was a survey, I think, of about 12,000 patients, and then they did a more focused survey with an interview with 25 patients and stuff to get more data. And effectively, it showed, I think, what some of us know, but probably forget, that actually online consultations can be quite positive. Let's make that a little bit bigger, shall we, Andy? There we go. So yeah, that blue table is probably the bit to zoom into on a little bit and stuff, the pros and the cons. So just waiting for Andy to be able to do that. So most patients, just scroll down a tiny bit, Andy. So other way, there we go. A little bit more. Other way. Other way.
Oh, you mean scroll up?
Yeah, sorry, scroll up.
Okay.
There we go. That's perfect. Yeah. So benefits. Most patients reported primary care benefits with quick responses and stuff. They also talked about the fact of being able to give a detailed information beforehand. And they felt it had a positive engagement with their GP and stuff because they felt it was a more personable service, and particularly because it was quicker, generally speaking. And the fact that the information was going direct into the records was definitely a positive step for many people's thoughts and things. The chatbots that some places may be using, although they asked sometimes quite specific questions, it felt was being thorough as well. And also, patients felt that it was safer because the information was looked at and stuff. But I guess cons, websites apparently was the big one, that they're overloaded with information. So I know a lot of the online consultation providers and even the NHS England's guidance is very much have a clean website, and there's support and funding to try and look at that with certain providers. Definitely recommend speaking to IHRO if you're interested in that. And about how clinicians may not have actually read the stuff that's been sent through, which I guess is always a comment and criticism to us in general practice, isn't it? That we ask the same questions again.
We don't get much prep time, do we? That's that's problematic. But then actually, if you if you do read it, it can save you time within the consultation. I think it's probably just a case of clinicians getting used to finding that information and assimilating it prior to the consultation. Yeah.
And then some patients didn't like being forced to use online consultations. I think that can be a challenge sometimes, because if you're trying to create a system that's equitable, you need suitable routes in. But at the same time, I definitely agree you should not force a patient to go down a particular route. And minority patients felt that online consultations may misdirect GPs to the incorrect diagnosis. And I guess that can be down to how much information you can gather. The whole concept of structured versus unstructured online consultations and things comes through in some of this. And there's some rhetoric in the article also about, the perception that GPs are not seeing people because they're doing online consultations, and that kind of stuff came through in some of the article. But overall, it seemed like a really positive thing that was coming through. So maybe a bit of evidence to suggest that actually online consultations can be really useful in the journey of a patient care.
It's nice to have a bit of balance, isn't it? Because if you just listen to some quarters, you'd get the impression that the patients did not like online access at all. They didn't like telephone consultations, and that it was all about face-to-face consultations. And that doesn't appear to be the full picture when you look at some of these articles and studies that have more rigorous methodology, like this one looking at 12,000 patients. So yeah, interesting. So it'll be interesting to see how this
12,000 comments, Andy, just to be clear, not 12,000 patients. 12,000 comments.
Okay.
They did interview 25
written
patients.
Comments. Yeah. But but input from 12,000 patients, that's quite a lot, isn't it? They're collecting the opinion at least from 12,000 individual patients, which is pretty good. Or a lot better than your average Daily Mail article, I would suggest.
I guess if we're talking about opinions, probably next thing to talk about would be the GP survey stuff. So I know you and I are quite opinionated when it comes to the GP survey, but there's been some changes suggested, hasn't there, Andy?
Yeah, well, I think they're being kind of telegraphed. They're letting us know that the GP survey will change from next year. We're being told that many of the questions will be quite different, and this will mean in some of the domains it will be difficult to follow trends from previous years, but it's being updated to reflect those contract changes around modern general practice, those changes that we talked about earlier in the year that were pushed through in terms of changes to the general practice contract, giving equity to how people contact their GP, online, face-to-face, on the telephone, and telling GP practices how they needed to deal with people's requests for appointments or requests for input. So that's part of what's prompted this evolution of the GP survey. They're not telling us which questions will change. They're not telling us what the new questions will be at this point in time. They're just telling us that it will change. They're also suggesting that the changes will help make the GP survey a better tool for ICBs as they decide whether or not primary care networks have met their access, their 30%, their access targets, on which 30% of the access improvement funding is dependent. So it will help feed into that. And, one wonders with changes to QOF and incentives, whether they are intending to do more with the GP survey going forwards. And it's part of bigger changes that we might see coming. So that's an interesting article, and it'll be interesting to see how that develops in the future. Any thoughts, Gandhi?
I think it needs to change. Unfortunately, a lot of the questions relate to appointments with your GP, or they've only just started introducing the fact that your appointments may not be with a GP, but actually general practice has rapidly changed from that. I've always commented that the concept of it being contact should be better rather than appointments, because appointment always gives that visualization of a physical face-to-face consultation. And actually, we know that that's not how modern general practice will work. So I welcome the changes, I think, in some ways. Would love to know what they are, as ever. But I guess we'll have to wait and see for that one, won't we, Andy?
Yeah, and we'll let people know, when we know and we come across it, we'll let people know and let people know what we think about it as well. So I'm looking forward to learning more about that in 2024.
Okay. So I guess next it'd be worth talking about some other updates when it comes to finance as well. This was one about the DDRB changes, Andy, that we saw coming through. You want to lead us through that particular one?
Yeah, absolutely. So the Doctors and Dentists Review Body, they're a sort of quasi-autonomous, like a quango, or they're not they shouldn't be directly controlled by government. They should be independent, although the BMA has had some challenge on that recently. But they review the pay of doctors and dentists in the UK and provide recommendations for pay uplifts yearly. They don't traditionally advise on pay uplifts for GP partners. And actually, a lot of GP partners will be sitting out there thinking, actually, we've been on a 5-year set contract for the last 5 years, expiring in April 2024. That's had roughly a sort of 2 to 3% increase year on year, and that actually has not kept pace with inflation. That's not kept pace with the increased costs in general practice, and that's not kept pace with the pay awards to other doctors whose pay increases are advised by the doctor and dentist review body. So a lot of GP partners will be sitting there thinking that's not fair, and actually a lot will feel that they've taken a real terms reduction in pay as they've had to increase the pay of other people who work in the practice, and the costs of operating their practice have increased, and the surplus that they actually use as their pay from that contract, has gone down over recent years. So Victoria Atkins, our new Secretary of State for Health and Social Care, has written to the Doctors and Dentists Review Body and asked them to look at GP partner pay next year. That's essentially the long and short of the story. Quite what the outcome will be interesting, and we'll have to wait and see. And then quite how they put the outcome into practice, really, because with GP partners, it's probably not as simple as just saying 5, 6, 7, 8, 20, who knows, % up increase, because we're not salaried. It's all about surplus from the practice. So they'd have to do something to the global sum payment to reflect an intended increase in GP partner pay. And of course, the proportion of doctor cover in any given practice that is provided by partners is very different. So it'll be a very difficult thing to put into practice, even if they do arrive at a figure that is felt to be reasonable. And of course, if that figure is not felt to be reasonable, what happens then? And do we potentially then see a disagreement with the DDRB and the government about what is an appropriate uplift to the contract, and maybe even leading to industrial action? Who knows? Those are my thoughts, Gandhi. What do you think about it?
I definitely echo those thoughts. I think it'd be an interesting. It's a complicated one, and I don't recollect the DDRB ever commenting on partner pay from memory. So if that is incorrect, please tell us, because we'd love to know. But like you say, there's a lot more complexity in there, because partner pay is based on surplus of income made from the practice, based on capitation, the various other funds like QOF and stuff. As you mentioned, we've seen year-on-year effectively reduction, because when you encounter inflation, the pay rises for staff and other kind of things, then actually partner income is massively dropping, which is why there's now less people being partners, which has an impact on practices. And that's why we're seeing practice closures and various other things as a result of it. So it'll be interesting to see what they come out with. We will absolutely cover it when it comes out, because I think more than anything, we want to read it. But yeah, it'll be interesting to see what the DDRB come up with. And more interesting, I think, is whether or not the government will use it as a badge of honor to say this is what we're going to do, or maybe shy away from it. I don't know. It'll be.
I don't know. They've asked for the opinion, haven't they? Victoria Atkins has written to them and asked specifically for their opinion. So it'll be interesting to see what they do with it when they get it. Probably just worth giving just another shout out to the BMA Practice Finance Survey. The BMA have suggested that they've said they will engage with the Doctors and Dentists Review Board on this issue, which is interesting in itself, because I think they currently have a policy of not engaging with this body because they dispute the level to which it is able to be independent from the government, but they are intending to engage. And actually, they say that this survey and the information collected on it will inform both how they interact with the DDRB, and also may also inform the DDRB's conclusions directly itself, because this will be data that they are likely to look at. So just encourage practices to complete that survey.
And I guess finally, we're going to talk about something that I think people have split opinions on, and that's whether or not PCNs are useful. And I guess the context we're looking at this is, which is a slightly loaded question, particularly for me, given a PCN clinical director, I guess. But this is specifically talking about an article that's come out that talks about health inequalities aspects of PCNs, and is it actually helping or hindering. And I think the summary of this is that it's probably not helping. Is that correct, Andy?
Yeah. So why is that? Because people will look at primary care networks and say, okay, this is new funding for all areas, for primary care in all areas of the country, whether they are rich or poor. And actually, within the primary care network, there are some areas that ask the primary care network to use some of this funding and their staff to directly address health inequalities. So how have we reached a situation where people are questioning whether they are helpful or not, and even whether they worsen the situation? So what's behind that thinking, Andy?
So, I mean, effectively, this looks at the concepts of the way that PCN's been working and funding. It talks about the mechanisms by which practices and networks are being funded as well. And it suggests that actually the adjusted population, which was this new metric that was brought in for PCN payments, is probably better at looking at payments for areas and stuff, rather than the raw list size and the weighted list size, which are traditionally used to offer payments for practices and things. And it was, like I said, introduced for some of the PCN payments, but also that it marks that in deprived or challenging populations, networks and stuff, the outcomes are still just not matching what they should be in other types of networks. And it talks, I mean, it's got numbers in there. It's got, I think, higher needs areas had 6 fewer full-time equivalent staff per 100,000 patients than those in the 20% least deprived kind of areas and stuff. So, and the funding just hasn't followed through in terms of what it needs to do to tackle inequalities. So this was a report by the Health Foundation, which we've covered a few of their reports before in the past. I can see Andy's got it had it up on the screen and stuff earlier and things. I think it's an interesting read. As ever, the Health Foundation seems to come out with some really interesting points and stuff. But the long and short of it, they're basically saying the funding model needs to change, which I don't think many people disagree on that. Particularly, I guess, people like you and me, Andy, who work in these deprived areas, because we know that the funding doesn't work the way it should do. It doesn't support the needs of the populations the way it should do. And until it does, the outcomes are never going to be great. We know vaccinations outcomes in deprived populations are just still continue to be awful. And I think a massive part of that is down to the way that the care was funded. And again,
I think for me, it comes down to that funding model, really, because what we've had with primary care networks is additional money for primary care and for general practice, and the opportunity to recruit additional staff. But the whole sort of thing about health inequalities really is that where there is the highest need, you get the worst access. And actually, in order to address that, many people would say actually you need to target additional funding preferentially at areas of high need, so that you can recruit more staff to those areas to address those health inequalities and get better outcomes for those people. And actually, what we've seen with primary care networks is that actually the eligibility for funding is sort of the same in all primary care networks, whether they're in a rich area or they're in a poor area. So they're not really addressing things at the funding level. And then you find all of those old problems still there in terms of it's harder on balance to recruit to deprived areas compared to areas that are not so deprived. It's easier to get those staff into those areas, seeing the patients. And even though the primary care network DES mentions health inequalities and has some sections targeted on that, it's about reducing health inequalities within the geography of the PCN, not between primary care networks. And the whole idea about primary care networks is that they group similar communities and similar patients together so that you can do population level things which are tailored to their needs. But what that means is that the focus is on addressing health inequalities within a population that experiences health inequalities on whole, rather than addressing health inequalities across an area covering different primary care networks. Hopefully I'm getting my point across, really. But I think it's probably fair criticism, and probably coming at a good time as we're looking at new contracts, as we're looking at a review to how incentives work in primary care. Perhaps something can finally be done to help address health inequalities. It's a really interesting story.
It is, and I guess particularly for myself and Andy, like we said, we work in these kind of populations, so we're very passionate about this. Does the funding model need to change? Absolutely. Does NHS England need to sort themselves out when it comes to the way that they pay for these things? Absolutely. I've not shied away from criticizing them, particularly the Vaxnim stuff for the IAF and QOF has been an absolute disaster in my mind, because they continue to fund it based on factors that just make it so much more challenging to achieve. And actually, we're seeing reduced vaccination rates in those populations because the funding has not matched the needs of those populations. I better stop ranting, because otherwise I'm going to get into trouble. So apology on that. Andy asked me to stay positive. We are finishing off the year, so I think we will make sure we finish on a positive and things. But it'll be an interesting thing to see what happens in 2024 when it comes to these things.
So Gandhi, obviously we've got our review episode, which will go out next week, where hopefully we are being a little bit more positive, looking at highlights from the year and looking forward to what will be happening in 2024 and what we're excited about, and also looking at our last 5 years of predictions and whether they've come true or not, and making predictions for 2024. So people can look forward to that next week.
Definitely. Yeah.
Gandhi, can I ask you to end on a positive note? Anything positive happened in the last few weeks in the world of general practice? I'd like to end the year on a high note.
Absolutely. Well, if people do want to check out that episode that Andy's talking about, have a look right here. Alternately, if you want something really fun, frivolous, and positive, then check out our Christmas episode that was absolutely fun to do and got really cool hints and tips and stuff. And that's coming up right here for you if you want to watch that. So definitely check out those 2 episodes and stuff if you want some fun, frivolity, and positivity just in time for Christmas.